Good afternoon. Today I will be presenting a clinical case of a 56-year-old man that was diagnosed with male breast cancer with multiple brain metastasis. Here is the table of contents of what we're going to be seeing today during this presentation. So let's start with the patient's initial presentation. The patient was admitted to the hospital because of an intermittent headaches that had been present for about 1 year. But during the 2 weeks before the admission, his symptoms worsened. And this is because they were accompanied also by vomiting and blurred vision, which prompted him to seek the medical attention. While taking his history, it was discovered that he had also noticed a lump in his right breast approximately 10 years earlier. However, he had never sought medical evaluation or received treatment for it. His review of symptoms was positive for headache, vomited, blurred vision, and balance and coordination problems. No additional systemic symptoms were reported in this case. Regarding his medical history, the only significant finding was the untreated right breast mass. The article did not provide information about his personal or social history, including if he smoked, if he consumed alcohol, about his occupation, medications, allergy, nor family history about breast cancer. But on his physical examination, the patient showed signs of cerebral dysfunction, including cerebral ataxia, a positive Romberg sign, also an abnormal finger-to-nose and heel-to-shin testing on the right side, and an examination of the breast revealed a hard, poorly mobile right breast mass measuring approximately 2 centimeters. The diagnostic imaging demonstrated multiple enhancing lesions in both cerebral hemispheres, with the largest measuring 39 by 29 by 29 millimeters. The MRI also shows surrounding edema and mass effect. The PET-CT scan confirmed hypermetabolic lesions in the cerebellum and the left parieto-occipital region of the brain. Also, there was a pathology of the breast mass that revealed an invasive ductal carcinoma. It was a grade 2. So, while the brain lesion was confirmed as metastatic breast carcinoma. And the immunohistochemistry it showed estrogen, that the receptor positivity of about an 80%, and the progesterone receptor positivity of about a 60%. So we also received HER2 1 positive and an EGFR negative, and a Ki-67 index of approximately 20%. So the final assessment was male breast cancer with multiple cerebellar brain metastasis, and the patient underwent surgical resection of the cerebellar tumor along with excision of the breast mass. Unfortunately, follow-up MRI 1 month later demonstrated new brain metastasis, and 6 months later the lesions had progressed despite surgery. So his condition continued to deteriorate, and he ultimately received conservative management. So, in conclusion, this case demonstrates how delayed recognition of male breast cancer can lead to advanced metastatic disease. Although male breast cancer is rare, persistent breast masses in men should never be ignored. So, this report also highlights that surgery alone is often insufficient once brain metastases are present, and this emphasizes the importance of early diagnosis and a multidisciplinary treatment approach, including surgery, radiotherapy, and systematic therapy to improve patient outcomes. Here are the references, and thank you.